Hello, I am Shania Rimpel, a third-year biology student from Northeastern University. I am currently a research assistant at Boston Medical Center's Recovery from Stress and Trauma through Outpatient Care, Research, and Education Restore Center, working with Dr. Al-Shabani on the adaptation and dissemination of a race-based stress, trauma, and empowerment RBSCE class for community churches. We are currently on the pretrial phase of this ongoing research study. Racism is an issue that has plagued the US for hundreds of years and can now be described as a public health problem. Black people in the US endure a higher stress burden and lower access to quality care caused by structural racism. While stressors are common in everyday life, Black people have the added race-based stress, RBS, defined as psychological stress or emotional injury responses that are experienced in response to structural and individual racism. RBS is not always defined by one specific event, but can be described as a chronic stressor found in both individuals and systems. This study aims to adapt and disseminate a race-based stress, trauma, and empowerment class for community churches to help address RBS. Our RBSCE research study is derived from Dr. Cromartie's study, Intersections Between the Black Church and Mental Health, establishing a community-based project. As we work towards the adaptation and dissemination of the RBSTE class, we expect that information gathered from our clinician, church, and patient advisory boards will aid in better understanding the needs of the local population, as well as helping us understand the best way to tailor RBSTE's curriculum and implementation plan. Chambers et al.'s Adaptome model will also be helpful in adapting the intervention for setting, audience, and delivery. The Adaptome model recognizes that at times, an intervention may warrant evolution within and across contexts. The Adaptome is also able to recognize that different adaptation of the intervention may exist, each providing benefits and disadvantages to the populations and systems that may receive it. The adaptation of an intervention using this model may choose to adapt it based on 5 sources: service setting, target audience, mode of delivery, cultural, and/or core components. As RBSCE is focusing on the needs of the local community, the addition of a church community advisory board was the best route to go. We will be able to discover the needs of the church in terms of race-based stress in ways that we otherwise may not be able to do. Community-based participatory research gives the local community the ability to have a voice in a study that will directly affect them. The aims of the RBSCE study are threefold. Aim 1 is adapting content and implementation. This aim involves recruiting and hosting community advisory boards for patients, providers, and church members. Adapting the content for both cultural context and delivery, plans of implementation for both BMC and in the church setting. Field notes taken at meetings and rapid coding of notes will be used to make adaptations. Aim 2 is piloting the intervention. Piloting the intervention will involve an 8-session version of RBSCE, which will aim to have patients who have experienced anti-Black racism. During this pilot, feasibility and acceptability will be evaluated, and enrollment, retention, and participant satisfaction will be tracked. Aim 3 is refining and sustaining. After piloting the intervention, we will present the community advisory boards with data to continue refining for the church. Church members will be trained to facilitate RBSCE groups, and we will continue to provide ongoing consultation. Plans to sustain RBSCE post-award include ongoing training and consultation, continuation of hosting community advisory boards, and identifying next steps in addressing race-based stress. Presently, we have obtained IRB approval prior to initiating recruitment for both the clinician and church advisory boards. In recruiting the clinician advisory board, clinical supervisors nominated clinicians who they believed would be interested in joining. We outreached nominated clinicians, sharing more information about the study and their prospective role. The principal investigator further explained the project after reviewing materials. Clinicians that were interested in making up part of the advisory board voluntarily participated. Recruitment for the Church Advisory Board was done via pastoral buy-in in order to gauge interest. Church leaders, such as pastors and priests, were asked to nominate members of their congregation who could best represent the community. Members that were nominated and interested reached out to the research team via email or phone to ask for more information about their role in the study. The Patient Advisory Board awaits IRB approval. Thus, we have not started recruitment. Patients will be nominated by the providers from programs at BMC, such as the Immigrant Refugee Health Center, General Internal Medicine, Family Medicine, and the Recovery from Stress and Trauma through Outpatient Care, Research, and Education Restore Center. The RBSCE intervention that we are adapting was originally developed to support veterans of color who have experienced racial stress and trauma within the Veteran Health Administration. RBSCE is an 8-week session, with each session lasting 90 minutes, with topics ranging from addressing race, white privilege, validating the impact of race-based traumatic experiences, and empowerment. Our clinician cab is the most far along of our advisory boards at this point. Clinicians have expressed the importance of fostering a safe and brave space for BIPOC, intentionality regarding integrating mindfulness and spirituality, as well as acknowledging the mistrust that BIPOC may have regarding psychology. We are in the process of forming our church cab. However, some difficulties have arisen, such as finding suitable meeting times for all advisory board members, as well as hesitancy to join a research study based on a history of mistrust. As we progress through the next steps of the adaptation and dissemination of an RBSCE class for community churches, we plan to launch meetings with the Church Community Advisory Board, await IRB approval to begin recruitment for the Patient Advisory Board, the dissemination of the adapted RBSCE manual, and finally, assessing the outcomes of RBSCE groups. Thank you so much for the opportunity to present our abstract. I hope you enjoyed.